and Dr. Kennedy from the American Medical Group Association. They've been doing just great work, great supporters of the Right Care Initiative. I've had the pleasure of knowing Jerry for some time now when he was with Sharp Reese Staley giving leadership through the Integrated Healthcare Association. He's now president of the American Medical Group Association and CEO, and then also the foundation as well, Dr. Kennedy. So they're going to lead us through some of what they've been doing over the next half hour or so. Jerry and John.
Good to see you. Thank you. And I'll go ahead. Why don't I like to invite the panel to come on up, and we have a group of very distinguished speakers. And I will not take much of your time because I've learned that we have to keep on time is a very important thing. We learned that this morning. Anyway, I left California 6 years ago. I left San Diego, to be specific, as Dean Shortell mentioned. I was with Sharp Reese Staley for over 20 years, and now I'm in Washington, D.C. The first question I always get, why would anyone leave San Diego? But I did leave, but I took with me all the wonderful lessons that I gained here in California from Right Care Initiative, from Sharp Reese Staley, and from wonderful medical groups and many of the people here in the room that taught me so many things. And my goal at AMGA, a national trade association, and we represent over 400 medical groups. You're going to hear from 3 of them today, 3 of our distinguished groups that John Kennedy will introduce. But what we try to do is take the lessons that I've learned, and my goal again is to take the lessons that I've learned mainly in this room and from leaders like you, and bring them to the national level so that we can improve care for millions of patients. I'm very honored to be here, and with that, I'd like to turn it over to Dr. John Kennedy, who will be leading us through the program.
Okay, well, thank you, Jerry. And we're going to do a little practice session here. Excellent. So today we have a panel discussion that's featuring 3 AMGA members and Together to Goal participants. Dr. Beth Averbeck, Senior Medical Director, Primary Care at HealthPartners in Minneapolis. Dr. Christopher Jones, Internist and Chair of the Diabetes Clinical Programs at Intermountain Medical Group in Salt Lake City. And Dr. Phil Oravetz, Medical Director, Accountable Care at Oschner Health System in New Orleans. The panel will be moderated by your friend and mine, Hector Rodriguez, who is professor here at UC Berkeley School of Public Health. And then we're going to be following this with a deep dive into some data, so I hope you had some lunch. Dr. John Cuddeback, Chief Medical Informatics Officer at AMGA, and Dr. Jim Duddle, Diabetes Champion at Kaiser Permanente, and they're going to be talking about how they dually discovered the same phenomenon on opposite coasts simultaneously. So very interesting. All right. So at this point, I'd like to tell you a little bit about my background. I am the AMGA Chief Medical Officer, Jerry's old job, and president of the AMGA Foundation, which means I'm in charge of the philanthropy and the quality improvement programs for the trade association. For the last 10 years, I was at Geisinger Health System in Pennsylvania, and I was the endocrinology director for the Geisinger Health System and chairman of the Diabetes Care Transformation Committee. I was very pleased to see Geisinger as one of the top 10 performers on the national scene in hypertension, so that was very reassuring. So what I really want to do is to kind of transition from the role of endocrinologist and diabetes specialist and transition from the role of a Geisinger system director and talk to you more about the larger AMGA programs today in my new role. It's important to know that all of our presenters and the moderators have no relevant financial information to disclose. And so AMGA, if you're not familiar with it, the American Medical Group Association, is a nonprofit trade association that brings multi-specialty medical groups and other organized systems of care together to improve health care for patients nationwide. Sounds a lot like what you're doing here in California. Now, AMGA's membership is actually well represented here in the room today, with many of California's highest performing health systems in attendance and in our membership. AMGA represents 170,000 physicians in over 400 medical groups, delivering health care to 120 million patients. That's 1 in 3 Americans nationwide. The Together to Goal campaign is our diabetes initiative, which is put on by the AMGA Foundation. Once again, AMGA's philanthropic arm. The Together to Goal campaign is data-driven and challenges participating medical groups and health systems to improve care for people with type 2 diabetes by sharing best practices and disseminating the most effective tools and research. So the blue states are the states that have program participants. We launched the Together to Goal campaign in March of 2016 when I served as national advisor to Together to Goal, and I was still in my role as leader of Geisinger's 35,000 patients enrolled in this campaign. Now that Jerry has moved up to his esteemed position, and I am now the AMGA Foundation president, I get to lead 61,000 physicians who care for 2 million patients with type 2 diabetes in the campaign. Thanks a lot, Jerry. These are the planks. So to help improve outcomes, the campaign offers 11 evidence-based care processes, or campaign planks, and these 11 planks fall under 3 different domains: empowering patients, improving care delivery, and leveraging information technology. Participating groups can adopt 1 plank, all 11 planks, or anywhere in between, depending on where they're at on their value journey. And the campaign is designed so participants can customize a program based on their capacities and priorities. And to help them, we have a toolkit. So to help groups implement these planks, all of the members can contribute information to the campaign toolkit, which can then be shared by everybody else. So this includes an in-depth description of each plank and an accompanying tool from some of the country's leading medical groups and health systems. So for instance, groups can learn how Community Physician Network in Indiana organizes its diabetes team, or how Sutter Health helps patients with diabetes set SMART goals, or how Wake Forest embedded point-of-care tools. So we encourage all the participants to adapt these tools and adopt them to their own local environment. In addition to the toolkit, we have a whole series of additional resources. So we offer participants monthly webinars, we have videos, we have newsletters, in-person meetings, online forums, and other resources to help them get their patients to goal. And this is our big audacious goal. So this was the D, right, that was missing from the Million Hearts. So our goal for this campaign is to improve the care for 1 million people with type 2 diabetes. So you see how we're complementary here. Right? We work together. Okay, so how are we doing? So to track progress towards this goal, we have the AMGA analytics team. And we have our campaign participants who can elect to report on 4 diabetes measures. You know them well: A1C control, blood pressure control, statin prescription, and medical attention to nephropathy, as well as a bundle of those 4 measures on a quarterly basis. So now we can see what's working best, and then we can compare against a national database similar to what you're doing here in California. And it's a very healthy competition, as I've heard from the South and the North here, all looking at each other's charts and trying to get better. So from this data, we've determined that in the first year of the campaign alone, our groups are reporting data improved care for over 477,000 patients with type 2 diabetes. And if you include all the groups who are participating in the campaign, AMGA Analytics estimates that a total positive impact for over 600,000 patients with diabetes in 1 year. So that puts us well on the way towards our goal of 1 million patients improved in the 3-year plan for the Together to Goal campaign. But we aren't done yet. So as Jerry likes to say, I like to win. And the reason is because if AMGA wins, that means that our groups win. And if our groups are winning, that means that 1 million patients have improved their diabetes control. And what that means is that their communities win, and that's really our vision for 2025. And I hope you agree that's the right care for patients with diabetes. So with that in mind, I'd now like to turn this over to Professor Hector Rodriguez.
Thank you, John.
And I'm going to actually give you this.
Oh, perfect. So great. There's three things we'd like for you to take away from our presentations today. One is to appreciate the multiple different tactics and strategies that can be used to improve diabetes outcomes among patients, and improve a bundle of these, not just one or two. We also would like you to appreciate and learn novel ways to engage the entire care team and patients in improving outcomes for diabetic patients. And then finally, to discover the benefits of participating in Together to Goal as a peer-led campaign. So first, we'll hear from Dr. Beth Averbeck, Senior Medical Director of Primary Care for HealthPartners in Minneapolis. She's responsible for overseeing 350 physicians, nurse practitioners, and physician assistants at various primary care sites throughout Minnesota. Her presentation will focus on the benefits of standardizing a workflow while simultaneously customizing care for each patient. Next, Dr. Chris Jones of Intermountain Medical Group in Salt Lake City will present. Dr. Jones is a diabetologist and serves as the chair of the Diabetes Prevention and Treatment Development Committee. He will share how Intermountain Healthcare has integrated pharmacists onto its diabetes care teams. Lastly, we'll hear from Dr. Phil Oravetz of Oschner Health System in New Orleans, and he'll present on innovative technology in diabetes care. They've developed an O-bar, which he'll explain. He has been with Oschner for more than 20 years and is currently the ACO medical director. After these presentations, we'll pose a few questions to the group and have a discussion about these strategies and whether they're feasible for implementation in your organizations. So with that, I'll hand it to Dr. Beth Averbeck.
Thank you. Pleased to be here, and in addition to having the opportunity to share this morning, had the opportunity to learn. So for all of you that shared, thank you. I was taking lots of notes that I can bring back to my organization, so I think that's the benefit of collaboration here. A little bit about HealthPartners. We are an integrated care delivery and financing organization in the Twin Cities, and everyone says Minneapolis, but I live in St. Paul, and there's a little healthy competition between the two cities, so I sometimes say it's St. Paul, Minneapolis. But we have about 35 primary care clinics in the Twin Cities, and we have a couple of critical access hospitals in western Wisconsin. So our geographic spread ends up being about 120 miles between some of our clinics. And the size of our clinicians can vary between one physician and advanced practice clinician all the way up to 25 in primary care, just to give you an idea. We are not mutually exclusive with our health plan and the medical group, so about half of our patients come from our own health plan and half from other health plans, and we take care of Medicaid and Medicare as well. And then I maintain a clinical practice in geriatrics, so that's just a little bit about my background. And it would be really easy if it were just one thing to help improve diabetes. It's not, it's everything. And I'm just going to try and give you a quick overview and a brief introduction to our approach for improving diabetes care. We started by saying, and back in 2005, we went on our electronic health record. And earlier, we talked about reliability this morning. Well, we know that any inconsistencies in workflow actually just get magnified when you've got the electronic health record, because why would you build something 350 different ways if you could build it one way? And we also know that there's no way one individual can do all of the work for a given patient panel, and we've got well-trained, well-motivated members of the care team, and we took some time out after we went on our electronic health record to say, if we had to do it all over again, how would we do it in a way that would be reliable for our patients and improve joy in practice for our care teams? And that led us down the route of standardizing the workflows and then customizing to the patient. And for common language, we use some lean methodology and reliability science, if you will. For common language for our care teams, we've called it care model process. And for us, it's just the workflows that we have. And we did 3 clinics. We did 3 days design session, used patient input. And then you can see along the way here, there are different roles and responsibilities for each member of the care team. We use a lot of standing orders, whether that be for the LPNs to identify health needs for preventive visits and for chronic visits. I mean, when I trained, I was trained in this is a preventive visit, this is a chronic visit, this is an acute visit. Patients don't come to us that way. They come when there's a perceived need. And part of our goal then was how do we give all recommended care at every visit, because we know for a lot of patients, either for high deductibles or for transportation concerns, they're unlikely to come back. So that's been our approach. And each of our clinics had the care team that I showed before. Then we have what we would call our neighborhood care team, if you will, where we have pharmacists and diabetes educators and dietitians that might cover 3 to 4 different clinics and might be there a day a week. And so they're a resource for our care teams that need extended help for patients newly diagnosed. I mentioned earlier the geographic spread. We have done some televideo visits with our pharmacists in some of our more remote areas where the patients don't have to travel, but they can do this electronically. So that's one of the ways that we're leveraging televideo. And then we talk about the electronic health record being a decision tool or providing that support. But the EHR isn't necessarily designed initially to do that. I think as upgrades have come, things are getting better. We have a research foundation that works really on health system research, and we partnered with them to say, what if we could use the electronic health record to help identify cardiovascular risk and provide some decision support at the point of care for patients and for clinicians. And so we did this with our researchers. And initially started as a diabetes wizard, and then it went and broadened to Cardiovascular Wizard. And this is how it works, and it was co-designed with clinicians and our researchers. When the nurse takes the blood pressure, there's an algorithm that then is calculated based on reversible risk. And there are 2 different views that are then printed and put outside of the room, one that's the clinician view and one that's the patient view. And then the clinician can go through that with the patient and then use that as a shared decision-making tool. And this is a clinician view, which will prioritize the reversible risk. And so at the upper right, this person's 10-year cardiovascular risk is 25%. And then it prioritizes where the most impact could be if the patient wants to make a change or if there's a medication change. So for this example, smoking is the #1 priority. If the patient's interested in smoking cessation, then we could do a referral. The #2 priority would be lipids. And so this is the clinician view. Now, some patients that are very highly educated like this view better than the other view, so we have a couple of options. And this is one of the pop-ups that would then come. So if you pull that box up, I thought I would just show you that not only does it give you the priorities, but it gives you some specific recommendations on medications. In this particular instance, it'll say, this person's had an elevated blood pressure, we don't see hypertension on the problem list, do we need to make that diagnosis? And do you want to treat? And the way we've worked at it with our researchers is to do the most cost-effective medications that are evidence-based first, so that helps us around the affordability lens as well. And then this is the patient view, and so to really trying to use the visuals. So if I'm a patient, and we try and do our patient education materials that are around the 5th grade literacy in general, but if I see the heart and the check, I know I'm doing okay there. If I see the triangles, that means I might want to do something different. The more triangles, the worse it is for me as an individual. But again, we can use this with patients to say, do you want to make changes, or could you make changes? And if so, here are some opportunities. And then really working with motivational interviewing on where our patient's ready to make a change, and then implementing those changes in partnership with our patients. And this is, once we did it with our system, we did it with our researchers, and we saw that improvement in blood pressure, we saw an improvement in A1C. Actually didn't make much of an improvement in lipid control. But then after we did it with our researchers, we spread it to all of our clinics. And then another care system in the state of Minnesota adopted it as well. And this just shows when they adopted the Wizard, they were able to see an improvement in their hypertension results compared to the state average, where they had been below prior to that. And this is our physician satisfaction survey. And the summary really is the physicians thought that it made them more likely to talk about cardiovascular risk. It made it easier to talk about cardiovascular risk, and it made it faster to talk about cardiovascular risk. And so from the standpoint of physicians wanting to do the right thing and actually making it quicker in the workflow, this was a win. And now, after the research protocol has been done for a number of years, we still see 70% use on patients where it triggers based on cardiovascular risk. And then moving on to kind of our neighborhood care team, if you will, we've done work with our pharmacists, and this was a study that was done by one of our researchers using remote monitoring for blood pressure. And these are patients that weren't in control already, so for our medical group, we sit at about 80% of our patients with hypertension in control. So this was the 20% that weren't in control, and then they were randomized to usual care or to have pharmacists work with them around remote blood pressure monitoring and protocol-based care. And so you can see that with the protocol-based care, that we saw an improvement in blood pressure that continued to be improved after the research protocol was done. So patients that were in control, for the most part, tended to remain in control. So I think this is a nice example of where that partnership with pharmacists can really make a difference for patients. And for the care teams, really accepted this as far as helping manage our patients. And then we also did a study with our pharmacists where this was actually done with one employer in the state of Minnesota, where patients were given an incentive around no copays for chronic medications if they agreed to see a pharmacist for helping them manage their diabetes. And then compared to patients that had usual care and didn't accept that opportunity to have them co-managed with pharmacists, we saw improvement here in a number of the metrics for diabetes care. So again, nice partnership on how pharmacists can help us on the care teams. And then based on a couple of years of analysis, also decreasing costs in that group that worked with our pharmacists around decreased hospitalizations and decreased emergency rooms. So net savings for that employer and for those patients of almost $1 million. We also worked with our endocrinologists on saying, what's the best way to partner with our specialists? And we did a couple of different models, and I would say this is the one that has stuck over the last couple of years. It's modeled after the ECHO model in New Mexico, where the idea is instead of moving patients, how can you move knowledge? And if you can have a specialist work with primary care, does that knowledge actually then spread to other patients? And that's the premise of this. It's a webinar-based learning opportunity, grand rounds, if you will, where an endocrinologist and a diabetes educator will do 20 minutes of didactic, and then about 8 physicians will be on the webinar, and each presents 2 patients, where the endocrinologist will give recommendations and the primary care clinician can follow up with the patients on that. We have seen improvement in A1C with this. This is really focused around glycemic control. We've seen an improvement in A1C for the patients that have gone through this and for the panels of our clinicians that have gone through this. High remarks as far as CME. We provide CME for it. And we also anticipate that this saves about $100,000 per cohort, because these are generally patients that otherwise would have needed to see an endocrinologist because they weren't progressing on the usual care pathway. And in Minnesota, we also like bundled measures. We have a history of these all or none measures, and Minnesota Community Measurement is our collaborative in the state of Minnesota that publicly reports on a number of metrics. And for us, the metric that we use for diabetes is optimal diabetes, is defined as these 5 components with the idea that this will decrease cardiovascular events. And Minnesota is one of the few states where cardiovascular disease is the second leading cause of death and not the primary leading cause of death. And again, I don't know that it's necessarily correlated, but we think that it probably is. And we are also looking at disparities as well. This is within our medical group, and we know that when we standardize, we see improvement for all. We don't necessarily see that we narrow the gap, and we've looked at this for our medical group in a couple of different ways to measure disparities. First, we measure based on patient self-identified race, and then we also measure based on socioeconomic status, and we don't say that or assume that one is a proxy for the other. And then our state also has got an annual report where there's a disparities report and an equity report as well, so that we can see how we're doing compared to other systems and compared to the state average. So this is where I think I know where we're headed next, Because when we look at our gap is not on testing. We're measuring blood pressure, we're measuring A1C. We're at 95% for all populations, but we're not at 95% for outcomes for everyone, and so that's where we're headed next. So with that, thank you for your time.
Next we have Dr. Jones.
Thank you, Beth, and thank you, Hector. Excellent. I'm honored to be here today, and in light of everything that's been said, I will let you know that what I'd like to do today is to talk about one particular item that Intermountain's been doing that is a very practical approach to one thing that we're doing amongst many things as we are involved with our approaches to diabetes care. This one is about pharmacists, and so we've modeled a pharmacist being embedded into the primary care medical home clinic. There's a lot of data about pharmacists improving care, and we wanted to see where is the best place for care. So we had some pilot studies where, or at least a particular one, that we had a resident pharmacist in a clinic who focused on a single goal, hypertension, and focused on a single clinic with a single cohort of patients. And they had one responsibility. We measured how this went to see if there was any outcomes improvement on hypertension with all of these patients, and found that our small pilot was successful. And so we pushed forward with other clinical areas. And the other clinical areas that we moved to then were medication adherence in a Taylorsville clinic and transition of care. And these were the next approaches that we took with our pharmacist. So as I explain this, I'd like to make it clear that the pharmacist was given an actual physical place in the clinic, an office, and a care team. And part of the care team was still led by the primary care physician. But in becoming part of that care team, they would have medical assistant help and patient care representative help, and be embedded into that system on a very local level. So we have a pharmacist who, we have a pharmacist inside of a clinic then working directly with the primary care physician, and we advanced to medication adherence, and we said if the pharmacist focuses on medication adherence, will we find data that's also acceptable or even greater than we would find if the pharmacist is just in the pharmacy or our community-based pharmacist. So under this collaboration, we had the pharmacist set up in the clinic. The care manager would help to grab the patients that were needed by a list that was pre-printed, and they would get patients into the pharmacist, and the pharmacist would see them when they're there. They would contact the patient either directly or by telephone, and they found that 50% of those patients then would not only benefit from, because of their statistics and numbers, but also would be willing to come see a pharmacist. The conversation was started by these pharmacists asking, how are things going with your medications? Focusing again on medication adherence. The patients were very open. We found the patients to be quite responsive to this approach. We assessed the reasons for non-adherence, and the pharmacist went through and made a medical plan with each individual patient. And so this particular role had a positive impact statistically. We had an increase in hypertension medication adherence by 92, or an increase up to 92.8%. It's a 26% increase from baseline for medication adherence for these patients. We could see similar results with cholesterol and diabetes medications, as you can see up here. For each intervention that was made by this pharmacist, medication adherence improved when they were working directly with the care manager, medical assistant, and primary care physician in their clinic. So we did a similar thing in a different clinic, multi-specialty clinic with a large primary care clinic that was a transition of care focus. So this time our focus, we had a similar process where the care guides or care manager would help to find the patients and recruit them. They'd schedule and then the pharm would go see the patients. They'd do their medication reconciliation, and I think we're all aware that there's a transition of care that is actually modeled by CME and such that is a prescribed set of requirements. They'd go through all those requirements for a transition of